Welcome back to Decode Healthcare with Harshal. In our last explainer, we completely conquered the larynx, right? Well, today we're moving even deeper into the respiratory system. We're going to demystify the trachea and bronchi codes, specifically CPT codes 31600 through 31899. So if you've ever found yourself staring at a chart totally confused by when to bundle a bronchoscopy or how exactly to code for an emergency airway access, well, you're absolutely in the right place. Let's get into it.
Real quick, here's our roadmap for today. We'll start with a welcome to the airway, then hit tracheostomy, dive into those crucial bronchoscopy rules, check out thermoplasty, look at excision and repairs, and finally, prep for the lungs and pleura.
Okay, section 1. Welcome to the airway, the windpipe, and its branches. Because, accurate medical coding literally always starts with accurate anatomy. We have to know exactly where we are. Let's break this down into plain, simple English. Think of the trachea, your windpipe, as the main highway for air. It's the big interstate. The bronchi, on the other hand, are the exit ramps leading directly off that highway and straight into the actual lung tissue. So whenever we're coding in this 31600 to 31899 range, we're exclusively dealing with procedures performed on this main highway and these specific exit ramps. Make sense, right? Moving to section 2, incision, specifically the tracheostomy. Let's start with how a surgeon might actually enter the airway from the outside. A tracheostomy is pretty much exactly what it sounds like. A surgeon literally cuts a surgical hole in the front of the neck, goes directly into the windpipe, and inserts a breathing tube. Why would they do that? Well, it completely bypasses the upper airway, so the nose and mouth entirely. This allows a patient dealing with an obstruction or, say, severe respiratory failure to breathe directly through that tube in their neck. And you know what? This brilliantly illustrates our very first major coding rule for this section. Context is literally everything. You absolutely must separate a calm, planned procedure from an emergency, fast-action airway access. Look at the CPT guidelines. Code 31600 is for a planned, separate procedure. 3161 is also planned, but specifically for a patient younger than 2 years old. But what if a patient is crashing and the surgeon has to act right that second? We shift gears to the emergency codes. That's 31603 for a transtracheal approach or 31605 for a cricothyroid approach. So always check that operative report for the urgency of the procedure. All right, section 3, bronchoscopy golden guidelines. We're transitioning from cutting the outside of the neck to snaking a camera down the inside with these endoscopy codes, ranging from 31615 to 31654. It is just fascinating to see exactly how this instrument travels. Notice how the flexible bronchoscope is carefully fed through the patient's mouth, glides right past the vocal cords, goes down the trachea, and then branches out into the right or left bronchi. This is exactly how the surgeon gets a clear, direct view of that lower airway. Now, listen up, because for your coding exams and your daily practice, you absolutely need to memorize these 3 unbreakable golden rules of bronchoscopy. Seriously, these are going to save you from making the most common coding denials out there. Let's break them down one by one. Rule number 1 is the big one. The crucial point is written right there in the CPT guidelines. Surgical bronchoscopy always includes diagnostic bronchoscopy. Okay, what does that actually mean? Well, if a surgeon snakes that camera down just to take a look around and see what's wrong, that's diagnostic. But if they go in, spot a problem, and fix it, maybe removing a foreign body or placing a stent, that instantly becomes surgical. The rule is simple. The diagnostic look around is bundled into the surgical fix for free. You never, ever bill both. Okay, rule number 2 reminds us that the approach totally matters. Normally, a bronchoscope goes in through the nose or mouth, but what if the patient already has a tracheostomy tube in their neck and the doctor just slides the camera right through that existing hole? Well, the CPT manual gives us a very specific code for that, 311615. That's for a tracheobronchoscopy through an established tracheostomy incision. You definitely wouldn't use the standard airway codes here, simply because the anatomy being navigated is entirely different. And rule 3, that's all about the tools attached to the end of the camera. If you picture that glowing camera view deep inside the lung, you might see 2 very different actions happening. Code 31623 is for brushing. This is literally using a tiny wire brush to scrape off surface cells. But code 31625, that is for an endobronchial biopsy using forceps. Think of forceps as tiny little jaws that physically pinch off and remove an actual chunk of tissue. Brushing versus pinching.
Reading the operative report to see exactly which tool was used is literally the only way to nail down the right code here.
Moving right along to Section 4, bronchial thermoplasty. This is a super high-tech treatment for severe asthma, and honestly, it's pretty amazing. So for severe asthma patients who just don't respond to standard inhalers, the smooth muscle in their airways often thickened. And that causes the airway to aggressively squeeze shut during an attack. Bronchial thermoplasty uses a special catheter, fed right through the bronchoscope, to apply radiofrequency heat directly to those airway walls. Here is exactly how this procedure builds step by step. First, the surgeon inserts a wire basket catheter right into the bronchus. Next, that basket expands to touch the airway walls and literally glows with radiofrequency heat. Finally, this highly controlled heat physically reduces, kind of melts away, that excess smooth muscle. The result? The airway stays open, drastically reducing future asthma attacks. It's a real game changer for these patients. Now, coding this incredible procedure is actually surprisingly simple. You just need to check the op report to see how much of the lung the surgeon actually treated. CPT code 31660 is used if the bronchial thermoplasty was performed on exactly one lobe. But if the surgeon applied that heat treatment to 2 or more lobes, bam, you use code 31661. It really is that straightforward. Section 5, excision and major repairs. We're looking at codes 31750 through 31830. This is where we reach the heavy-duty structural surgeries at the very end of this code block.
Listen, these codes aren't for your quick camera scopes. Oh no, these are massive, highly complex operations. We're talking about tracheoplasties to completely rebuild a collapsing windpipe, or tracheal resections, where a scarred, narrowed section of the windpipe is actually cut out, and the 2 healthy ends are stitched right back together. Sometimes these procedures even involve harvesting ribs to use as grafts. So when you see these codes, know for sure that you are looking at major open structural surgery.
Okay, Section 6. Next up, the lungs and pleura. That wraps up our deep dive into the trachea and bronchi codes. But our journey down the respiratory system, yeah, it is far from over. Because what happens when we finally leave those airway tubes and enter the pleural cavity for massive lung removals, wedge resections, and video-assisted thoracoscopic surgeries? Make sure you're subscribed to this explainer series so you do not miss Part 5. As you prep for that next step, I want you to ask yourself, how will mastering these complex procedural rules completely transform your accuracy and value as a medical professional? Keep those code books open, stay fiercely focused, and I'll see you in the next one.